All right, respiratory emergencies. I will tell you that a lot of your patients are going to be respiratory patients. A lot of them. They're going to have, respiratory distress, pulmonary edema. They may have fever. They may be coughing up green stuff with cough. And you need to be able to do a differential diagnosis. Now, we've talked about differential diagnosis. That means you take all the information that you've gathered about your patient, whether it's a history of present illness, past medical history, their current signs and symptoms, the results of the vital signs and physical assessment that you get. You're going to pull all of that together and make a differential diagnosis. That means that if your patient has a temperature and respiratory distress, you can throw out pulmonary edema. That's probably not going to be what it's from. So you will create what you think it is based on what fits the profile. And that's why I tell you need to be making note cards. For every single respiratory disease or disorder we talk about, you need to have a note card that's got its name up there, the signs and symptoms, what you're looking for, how you're going to recognize it, what the vital signs do, what your patient going to look like, and then how you're going to treat it. So you need to have all of that stuff on your note card. We're going to cover probably 15 possibly disease processes tonight, which you'll be responsible for. So you need to make sure you keep all those separated because there are things that will point to one direction or another, and I want you to be familiar with it. So respiratory emergencies, we're going to be looking at respiration. We've covered respiration a couple times before this, so I will just kind of touch on that. But we're going to look at the respiratory process. Like on the quiz you had, I asked you about inspiration, expiration, whatever. You still have to have that in the back of your mind so that you can understand some of this. We're going to learn to recognize respiratory distress or breathing difficulty. We're going to look at the terminology that's associated with that. For instance, dyspnea. What is dyspnea? What does that mean if you break that down?
Difficulty breathing.
Difficulty breathing, not short of breath, difficulty breathing. That means they're working hard to breathe. So that is something slightly different. We're going to go over the respiratory conditions that I mentioned to you. We're going to look at using the medications that we've already talked about. With pharmacology last week, we talked about using the inhaler. We're going to look at that again, how to actually administer that, and some more information about it. And we're also going to look at the nebulizer. And somebody remind me to find one of those in the lab so I can show it to you hopefully tomorrow night. So those are the things that we're going to be covering tonight. And it's very important that you pay attention. It's very important you take notes. You're going to see this stuff over and over and over. Students always say that the medical assessment is the most difficult. Why do you think medical assessment is so difficult?
You're trying to figure.
Well, there are a lot of things it can be, but
figure out a diagnosis.
Like an accident.
yeah, you can't see it. If I've got respiratory distress, you can't see it unless I'm, all been out with. And then you're going to know it's respiratory distress. But, if you got somebody with a gunshot wound, hey, a gunshot wound, you can figure out how to treat that. Oh, you got an impaled object. I see that. I can figure out how to treat that. But with medical, the only way you're going to really do a good differential diagnosis is going to be through your interview with your patient and your assessment skills. So this is going to be a thinking person's part of the semester. It's going to be the medical. So focus in on it now because you're going to see it now through the rest of the semester. Tomorrow night we're going to start medical assessment. And let's see, what do you think the medical we're going to be doing tomorrow night is going to be? Respiratory. You can bet on it. Okay. This is just a picture of the lungs. Which side of the chest is going to have the larger lung? The right side because?
It has 3 lobes.
It has 3 lobes. Why?
Because the heart's on the left side.
The left side only has 2 lobes because the heart's taking up space there. So whoever designed this did a great job with this. So this is where the heart is located here. Now these are lobes, but they're not really separate. They're not separate compartments. They're connected, but they have some tissue there that kind of separates them a little bit, but they still have free flow through there. You can see the trachea comes down, and at the point where it splits, we call that a what?
Bifurcation.
A bifurcation. What do we call the point that it splits? Starts with a C.
Carina.
The carina, that's right. So make sure you know those words. Any disorder or infection or condition that's associated with the lungs or the bronchi is going to be a lower respiratory disorder. Whereas something, if you have a blockage around the trachea or the epiglottitis, something like that, that's going to be upper respiratory. So when we say lower, we're talking about the lungs. We're talking about the bronchi. We're talking about the alveoli. Okay, inspiration is an active process. We have to work to bring air in because we're bringing against negative pressure. So you're working to bring that air in. If you just sit there with your mouth open, air's not going to zoom in. But if you sit there with your mouth open, air will zoom out because that's a passive activity, correct? So with our inspiration, what's going to be the major muscle that we're going to depend on for inspiration? It's going to be the diaphragm. The diaphragm will do what? Up or go down? As it contracts, it's going to go down. And when it goes down, it's going to pull a lot of that chest. It's going to expand the size of the chest cavity so that it increases the negative pressure in there. What other muscles will be working? Yeah, the muscles between your ribs, your intercostals, all those, when they get tight, when they constrict, they pull the chest cavity out. So all that is going to be inspiration, and it increases the size of the chest cavity. You open your mouth, and air is going to zoom in. So the ribs move outward and upward, and when that happens, airs come in. Air comes in. Expiration is passive. You open your mouth and relax, the air is going to go out. The diaphragm relaxes, the intercostal muscles relax, between your ribs, the whole size of the chest cavity just decreases. It deflates, if you will. Okay, we've talked about adequate and inadequate breathing. Now, when you look in your textbook, I think your textbook says rate and quality and got one other thing. What is it? And rhythm. What did I tell you about rhythm that most people have? Regular, irregular. No matter what's wrong with it, it's almost always regular. There's a few instances where it becomes irregular. Usually those are going to be some type of neurogenic problem. Most of the time we breathe regularly, but you do want to assess for that. But when I tell you I want you to look for adequate breathing, there are two things I want you to assess. I've told you 100 times. What are they? Rate and volume. That's right, rate and volume. Your book uses three things, but when you're out there assessing in the field, if you look at rate and volume, you're going to get it right 99.5% of the time. We'll talk about those times where it's not regular. And of course, when your textbook says quality, it's really talking, part of quality is how deep of a respiration or how shallow it is, but it's also talking about airway sounds, you know, are they working hard to breathe? Or do you hear stridor? Do you hear rales or bronchi? That kind of goes under quality too. But you'll recognize that right away. But when you'll hear that, you'll see that on the patient. But when you've got a flat scenario on a test, you're looking for rate and volume. That's going to be a cutoff for you every time. So adequate breathing is someone's breathing well enough that they're not going to die from it. So it's well enough to support life. Signs of adequate breathing, you look at them and they're not having any distress. I look out here, except for the ones that, you know, are asleep with their mouths open, they're not really in any respiratory distress. You should be able to speak in full sentences if you're breathing adequately. And you'll have patients that are not breathing adequately, and you'll recognize it because they're going, I can't catch my breath. That person's not breathing adequately. But if you look at rate and volume for that patient, rate could be normal. Volume's not going to be good if they're going, right? So if you're looking at rate and volume, you're going to recognize that without even taking into account that they can only speak in 1 or 2 word sentences. But you may see this description in a scenario on registry. It may say, patient can only speak in 1 and 2 word sentences. So you'll know that's a sign of inadequate breathing. When you talk to your patient, If they are breathing adequately and outside of some other issue going on, they should have a normal mental status. One of the most common causes of altered mental status is hypoxia. So if they're not getting enough oxygen to the brain, then they're likely to have an altered mental status. So if they have normal mental status, you look at them, their skin is nice and pink, you know, their eyes are bright. You look at them, they look okay. Their color's good, they know what's going on, and their mental status is good. That's a sign of adequate breathing. So if I walk in and I started, well, you're probably not a good choice, but, you know, I'm over here assessing Jeremy, I can look at him, he's making good eye contact. He doesn't look like he's working hard to breathe. His skin tone is good. He doesn't look like he's in any distress. I'm going to assume that he's breathing adequately because he looks nice and pink. There's nothing to indicate that he's not breathing well. Okay, you can also, you will also determine the rate based on these parameters. 12 to 20 breaths per minute is normal for an adult. This is a normal respiratory rate. This rate doesn't have anything to do with the rate at which you bag a patient or how often you bag them when you're doing CPR or how often you ventilate them if they've been intubated. Those numbers are something completely different. This is normal respiratory rate. As I look around the room, some of you are breathing 12 times a minute, some of you are breathing 15 times a minute, some of you are breathing 20 times a minute. That's the normal range. So when you're looking at a patient's vital signs, you want to determine if they're within normal limits. And we will note that very commonly on our narration. We'll put vital signs, and that means within normal limits. It does not mean we never looked, right? Within normal limits. So for a child, the normal rate is about 15 to 30. That's a range. Because, you know, kids, what's the age range for children, pediatric patients? 1? Yeah, 1, 2. Actually, for something like this, we usually think, you know, about up to about 18 or so. But at least we start at 1. And on the upper side of that, like when we decide how we're going to use our AED, whether they're a child or not, we're looking for puberty. And, you know, that's not a cut and dry number or age. So you're kind of looking at your patient. So that's why these are kind of in a range here. Younger people, usually younger children, breathe faster. As you get bigger, even if you're still younger, you become more of an adult range. So that's why there's a range here. Infants, which is going to be from newborn all the way up to 1 year old, 12 months, it's going to be a range of 25 to 50. That's a pretty wide range because they triple their birth weight, you know. So the difference is quite large for the little guys. So these are the ranges that will indicate they're within normal limits just for normal respiratory rates. The rhythms are usually regular. My rhythm, my respiratory rhythm is irregular because I'm trying to talk and breathe at the same time. If I had a head injury, I might have irregular respirations. If I had something called DKA, which we'll talk about later, I might have abnormal respirations. If I was FTD, which is if I was fixing to die, I might have agonal respirations, which are irregular and very slow. Otherwise, they're pretty much regular. In an adequately breathing patient, usually their breath sounds are equal, and you can hear them on both sides. If you could only auscultate breath sounds on one side, and it's silent on the other side, what could that be?
Seesaw.
You have an adult patient, and I'm listening in quadrants on the right, and I hear sounds. I listen to quadrants on the left, and I don't hear anything.
Oh.
I could have a pneumothorax.
Yeah.
Think of anything else that could bring that about?
The lung liability.
Yeah. They don't have a lung over there. That's kind of scary, but it happens. Good catch. Inadequate breathing. Inadequate breathing is breathing that's not going to sustain life. You know, you got somebody breathing 50 times a minute. They can only do that so long because what's one of the major problems with breathing so fast like that? You're not getting enough oxygen, you become hypoxic. But what else is happening? working really hard to breathe. It'll wear you slap out. If you're already sick, something's wrong with you so that you can't breathe adequately, you're working that hard to breathe, it's going to wear you slap out. You're going to pass out. Signs. When I say we're looking for rate and volume, if it's outside of the normal range. Now, for it to really be a problem, it's going to have to be a little bit past just a normal range. We say 12 to 20 is normal, just like we say blood pressure is, normal from 90 to, 130. Above 130 to 150, they say it's pre-hypertension. Well, if you happen to have 132 one day, that doesn't mean you're hypertensive. Just means you're just a little bit out of the parameter. Same thing with breathing. If something's going on, you're breathing 22 times a minute, that might be within normal limits for you. And it might be normal. You could be breathing 10 times a minute and still be within normal limits for you. So just a little bit on either side shouldn't set off big old bells that there's a problem, unless there were other things going on. Irregular rhythm should usually tell you there's a problem, unless they're talking and breathing, like me. But irregular rhythm usually is a very bad sign for a patient. If you hear absent breath sounds, or you don't hear breath sounds in a lobe or in a side on either lung, that's a problem. Poor tidal volume, what's that mean? That's an easy one. Yeah, poor tidal volume, you're not moving much air. How much did I tell you is the amount of air in dead space?
150.
Good work. 150 cc's. That is an average, but that's a normal amount that's left in dead space. So what's the normal breath that you take? Just how many cc's is that? Yeah, about 500, 600 or so. So yeah, if we've got 150 in dead space, how much do we have that's usable here?
350.
Math guys. Yeah, not a whole lot here. 350, that's just normal. So you have poor tidal volume. If you're only breathing in 350, how much is in dead space? It's still 150 in dead space. So now, that same dead space is coming out. How much do we have now? There's a big difference between 200 and 350 in there. So that's what poor tidal volume is. Signs of inadequate breathing in kids. With little guys, you'll see nasal flaring. Y'all have seen them do it before. You look at them and their little nostrils just kind of go out like this. They're working hard. Do you remember what I told you about the little bitties? 1 month old, 2 month old, 3 month old, as far as their breathing? I think I've told you. But if I haven't, I'm going to tell you now. Does that look familiar? They're obligate nose breathers. So the little people breathe through their nose. If their nose is stopped up, they're going to have a very serious time breathing because they just don't open their mouth and go. We develop that when we get much older. They breathe through their nose. So with kids, you're going to see them flare out their nostrils because they want to breathe through their nose. I mean, I've seen them sometimes with their mouth shut. They go. It's like, open your mouth. Take some deep breaths. See if that'll help you any. Be familiar with this. They're obligate nose breathers. Infants primarily. Another thing that you will see with children is they tend to grunt. They go like that. And that is a very interesting technique that kids are using to help splint their alveoli. We call that auto peep. Now y'all are going, what in the heck is that? When they grunt, they're forcing air, they're increasing the pressure, the air pressure in their lungs. When they push that pressure down in their lungs, it forces the alveoli open. So they actually breathe better. Well, they don't breathe better, but they exchange oxygen more easily. So we call that auto peep. They're doing it themselves. PEEP stands for positive, that's, think of positive pressure, and expiratory pressure. That means they're just forcing that air at the end of their exhalation. They're grunting and forcing it back down into the lungs. Auto peep. Positive and expiratory pressure. Expiratory is exhalation. So that's what grunting is. And you see that sometimes with your patients that have COPD. You may hear them grunting. But oftentimes they'll do it in a different form. They'll purse their lips up and go. So they're actually blowing against pressure. It's basically the same thing. Kids just grunt it back there to force open the alveoli. With your COPD patients, they squinch up their lip and go. So they're exhaling against pressure. It's the same thing. Both of those are auto peep. Seesaw breathing. With little kids, real little kids, you may see their abdomen moving with their chest. It's kind of like seesawing. The abdomen is what's used to open the lungs rather than the diaphragm or the chest muscles. So you may see them working really hard, and you'll see their abdomen moving. That's going to be the little kids. Sternal retractions. You may look at somebody, kids in particular, but we see it with adults too, where when they're breathing hard, they go, and you see the muscles in their neck as they're straining to breathe. You see it right up around here, the sternum is here, the clavicles, you'll see it through there. So those are going to be physical things that you can see to tell you about your patient's breathing status. Would that be signs or symptoms? Are these signs or symptoms? These are signs because you can see seesaw breathing. You can hear grunting. You can see nasal flaring. Now, we talked about this a couple times before, and we'll hit this later on in the pediatric chapter. Kids have different structure to their airway than adults do. Their airway, of course, is smaller, but it's more easily obstructed for a couple different reasons. One in particular, and I believe I've told you this before, but I'm going to tell you again so you don't forget. What is the smallest part of an adult's airway? For the adult. The adult. The glottic opening. That's for an adult. That means our airways are kind of volcano shaped. This is exaggerated. But this is the glottic opening, and that's the epiglottis. It's very small, so crap doesn't get down there. Shouldn't say that, should I? We're not going to be swallowing marbles or anything. It's got to be pretty small to get past that. That's why we choke on meat and stuff. What's the smallest part of a child's airway? The cricoid. Yeah, you can remember cricoid. That's right. See, cricoid. So theirs is shaped just the opposite. This is their cricoid. So their glottic opening is larger comparatively. Their voice box is larger. So stuff actually gets past that. But their entire airway is smaller compared to the overall size of their mouth and their head. And heaven forbid, that tongue. So yeah, it's quite small. They have that big old tongue, and that if it starts to swell or if it falls back, it'll block the airway very easily. So if they've got that big old tongue in there, and it doesn't take a big object now to block the airway if it gets stuck even in their mouth. The trachea is more flexible. It's less developed cricoid. One thing too about a pediatric airway, when we talk about how we ventilate, how we position a child to ventilate them, for us, our airways, we tip the head back, we pretty much have a straight shot. But with children, their trachea is very far forward and very high. So if you can think about the little opening almost being right here, and if you tip their head back, it actually occludes their airway. Not so for us, because ours is set a little bit deeper. But when they're very young, it's set forward and very high. And if you tip the head back, you're going to block it completely closed. Kids also depend much more heavily on the diaphragm to breathe. They don't use their intercostal muscles quite as much because they're not as well developed. The diaphragm is quite large and it develops quicker, earlier than the intercostals and the other chest muscles. So that's where, as it moves up and down, that kind of tends to see that little seesaw breathing sometimes. Anytime you've got a patient that's breathing inadequately, unless they're just right on that line where, maybe I can put a non-rebreather on, it might be enough, so that they start breathing better. But if not, this is a patient that you're going to have to bag. And sometimes those are going to be patients that are conscious. It may not go so well for you. But if they're breathing inadequately, we know that they're not breathing well enough to sustain life, right? So if that's the case, we're going to have to bag them. We need to put them on oxygen. Now, how we actually ventilate them, we've got several choices. And I know you remember from CPR, because we got the little face mask for you to ventilate a patient with. You should have one of those with you in the car, in your bag, because that's what you'll use if you stop on the side of the road sometime. You may have to ventilate a patient. But the pocket mask with supplemental oxygen, according to the American Heart Association, is the best way to ventilate a patient. Now, we don't do that when we're at work. We just don't do it. We use a bag valve mask. But given the choice on National Registry, if it says according to American Heart, which is the best way to ventilate a patient, you will select pocket mask with supplemental oxygen. Why is a pocket mask so much better? Why is it better than using a bag valve mask? If you think about it, you'll come up with these answers.
Can't blow out somebody's lungs.
Yeah, you can't blow out their lungs. If you're using this and you get excited and you start giving this whole number when you use a bag valve mask, it's very easy to overinflate. If you put two hands on that, you can put 1,500 cc's in your lungs. What's a normal breath? 500 to 600. You just put 1,500 in there, you pop a lung. You're probably not going to pop a lung if you're ventilating through a pocket mask because you can't exhale that much. You can only exhale really a normal breath plus a little bit, and so you can't exhale enough to pop a lung unless you're doing a little bit of kid and you're a big old person. So how else is it good to use a face mask, pocket mask?
Can't hyperventilate.
Yeah, you can't hyperventilate because you can't breathe that fast. It wears you out blowing into somebody. If you're using a pocket mask, it wears you flat out. How many of you guys have done CPR yet? Did it wear you out?
I was wore out.
You wore out. It doesn't matter what kind of shape you're in. I've seen guys come and go in great shape. They're going, oh my gosh, somebody's got to take over these chest compressions. Yeah, about 2 minutes will do you. Same thing with ventilating a patient. What's so hard about ventilating a patient with your mouth? Do what?
Because it takes your breath.
Well, yeah, you're working hard. When you're breathing in, they're laying down, you're breathing in, the force of your breath has to raise their chest. There's a lot of weight on that chest, I'm sure it's 20 or 30 pounds sometimes, and you're blowing against that gravity, pulling that down. So it's work for you. But yeah, so you can't hyperventilate, you can't overinflate. So when you're blowing on there, you get something called compliance or non-compliance. That's one of those nebulous words. You just kind of have to figure out what it means. If it's compliant, if I'm blowing in there, I can tell when it's starting to get harder. You start blowing, it's like blowing up a balloon. It's a point where it starts to get easier, it starts to get hard. When you're blowing into a patient with that pocket mask, the more air you put in, the harder it gets. And you can tell when you put enough in there, you're just done. Even if you've got more air, it becomes non-compliant. Their lungs become non-compliant. You can only fill up so much in there. You can also get a better seal. If you've got both hands on there, you can tip the head back, and you can just blow right on there. You know when you're done, you don't overinflate. It's real handy. So if you see that, pocket mask is always best. The second choice is going to be 2 rescuer BVM with supplemental oxygen. That means somebody's holding the mask on the face to make sure they have a good seal, and then somebody else is squeezing the bag. So if you've got 2 people doing that, that's going to be your next best choice. So that's what you need to be doing in the field. You really need 2 people. And you can use a family member, you can use a bystander to squeeze that bag for you. You can say, too fast, not fast enough. I'm going to count it down for you once every 6 seconds. You know, you can monitor that. You can direct them. Further on down the list is going to be the flow-restricted, oxygen-powered ventilation device. I hate this thing. But you're going to see that on registry. I mean, there's a good chance you'll see this on registry. So look at it and go, God, what is that thing? And it's in your textbook. It is it's powered by your oxygen cylinder, and you set it for how big a breath you want to deliver to your patient. Whatever that is. We don't use it. Then the Venturi mask is another option to you. Be familiar with this terminology. With the Venturi mask, it's going to draw in outside air and mix it with oxygen, and they can actually adjust that in a hospital setting as to what the concentration of oxygen is that they want. And they will vary it based on the status of the patient. So we don't use that in the field. We don't use the flow-restricted, oxygen-powered ventilation device in the field because none of us can pronounce it. Okay, artificial ventilation. Artificial ventilation is going to be when you're bagging a patient. You are artificially providing air to a patient. That's what artificial ventilation is. And what's the difference between ventilation and respiration?
Ventilation is air exchange, like in the lungs, without the alveoli.
Ventilation is going to be the movement of air in and out of the lungs. You can do that to a dead person. You can ventilate a dead person. A dead person doesn't respirate. Respiration is going to be the exchange of gases, both in the lungs and at the cellular level. So respiration requires gas exchange. Ventilation is purely the movement of air in and out. And that can be adequate or inadequate. You can be bagging a patient and do it inadequately. How could you do it inadequately? What would be the characteristics of ventilating a patient inadequately?
Not having a good skill.
Yeah, what specifically?
Not having their mouth open.
Well, think about adequate and inadequate. Adequate breathing is what? Adequate rate and volume. So if you're ventilating them inadequately, you may be doing it too fast or too slow, or too much air or not enough air. Those are 2 of the main things you're going to be looking at. But it could also be that you don't have a good mask seal on there. Could be you don't have the airway open all the way. But one of the things you will be looking for is going to be rate and volume. When you're ventilating a patient, you need to watch the chest. Does it rise and fall? Remember one of the questions I think on the last test was about, or was it? No, I think it was the bridge students. If the patient has a stoma, remember, did we talk about stoma in here?
Mm-hmm.
They have a stoma, how fast are you going to ventilate them? The same rate. Are you going to tip the head back? Say you're ventilating a patient with a stoma and the air is going in really well, yeah, that goes in just fine, but the chest is not rising.
Close the mouth and nose.
Yeah, that air is escaping somewhere else. So some of your patients who have a stoma, they may have, it may be incomplete, meaning they can still breathe through the mouth and the nose. Others may have had that surgically closed and they can only breathe through their stoma. So if you're ventilating them at the stoma and it's going in just fine, the chest's not rising, that air's got to be going somewhere, right? Where else can it go? It can only come back out the mouth and the nose, right? So anyway, as you're ventilating, you should see rise and fall of the chest. And how do you know when you've ventilated enough? How do you know when to stop? As soon as you see that chest moving, you're done. Don't wait till it like gets big like this, you know. As soon as you see it move, you're done. Okay, artificial ventilation rate. This is going to be rescue breathing, if that helps you any. Rescue breathing, 12 times a minute for an adult, 20 times for infants and kids. This is only for rescue breathing. This is not for once they're intubated. This is not for CPR. This is if you're only providing ventilation assistance. These people, would they have a pulse or not? They have a pulse. If you're ventilating them 12 times a minute, they have a pulse. If you're doing it right. All right. Now, your textbook talks about increasing pulse rates, decreasing pulse rates. If the pulse rate is going up and there's nothing else that's changed, it may indicate that you're not ventilating them enough. It may indicate they're getting hypoxic, but it could also indicate a whole host of other things. So your textbook says this, but I don't put a whole lot of stock in it, because what else could make your heart rate go up?
You're worried?
You worried? Yeah, because I'm fixing that word. Yeah. Stress? Well, I mean, in the presence of somebody ventilating you. You're being ventilated. Internal bleeding, yeah. You're getting shocky because you're losing blood somewhere. Well, yeah, you're going to get tachycardic, and it doesn't have anything to do with your ventilation rate. So don't be locked into that. It's a possibility, yeah, but there'll be other things that are going to tell you. Same thing with decreasing pulse rates. Now, with your pediatric patient, if you see their pulse rates declining, it's much more likely that it's due to you ventilating them ineffectively or insufficiently. So with kids, anytime their pulse rate drops, it's never a good sign. And with kids, more likely it's going to be a respiratory issue than anything else. And we'll talk about that later on too. All right, how would you recognize the progression from adequate breathing to inadequate breathing in your patient? They're breathing adequately when you first get there. What signs or what things you're going to look at is going to tell you they're getting worse? Yeah, if their position changes, it could be they're starting to sit forward and breathe like this, or they may want to sit up and breathe. Where's going to be the most comfortable position for most of your patients to be in when they're breathing, if they have respiratory distress? Yeah, they want to sit at least part way or all the way up, depending on how bad they are. They're going to breathe better sitting up than laying down. What else would you be looking for? If they become cyanotic, certainly that would be a dead giveaway. If the pulse rate goes up, that may indicate they're getting hypoxic. I'm looking at you. What else might I look at? We mentioned cyanosis. To what? Yeah, altered mental status is going to be a quick sign of hypoxia. If they start getting, altered mental status doesn't necessarily mean they're talking crazy. It could mean that I was sitting up like this, but now I'm too tired to sit up, and I'm just going to lay back on my pillow. That's never a good sign. That's a mental status change. Yeah, if they now are not talking to you anymore, they're starting to get that glazy-eyed look, or they're starting to get pale, or you notice their respiratory rate increasing or decreasing, all of those are signs that you're moving from adequate to inadequate, or at least you're getting worse. Look for respiratory fatigue. That's what I mentioned. They were sitting up, now they're laying down. If you walk into a patient's home, you get called for respiratory distress, and you walk in their bedroom and the guy's laying down on a pillow trying to breathe, is that a problem? He's too tired to sit up. That's why he's laying down. If he's having trouble breathing, as long as he can do it, he's going to sit up to breathe. So watch for respiratory fatigue. Change in respiratory rates. They become tachycardic or particularly bradycardic in children will be things to indicate they're going down that slippery slope. Y'all want to take a short break before we start this segment? It is 6 o'clock straight up. Yeah? Okay, y'all scoot. I'm going to stop this for a second. Resume. That's good. Okay, next section. We're doing pretty well here. Okay, we talked about subjective and objective, right? When we talk about somebody that has difficulty breathing, that's going to be the patient's subjective observation. Okay, they're going to tell you, I feel like I can't catch my breath, but you've got a 98% O2 sat. They may feel like they're working hard to breathe. So notice these words, feeling, he says it's difficult, it hurts when I take a breath. All of those are subjective, but they're important based on what your patient tells you. It's just like If a patient tells you he has sharp chest pain when he takes a deep breath, or it feels like an elephant sitting on my chest, those two subjective descriptions tell you something completely different. So it's important that you listen to how your patient describes things. You want to see how much distress he's actually in. Sometimes they may feel like they're in a whole lot more distress than you think they are. They've got a pulse oximetry of 98%. They're breathing 16 times a minute. Their skin is pink. You've auscultated clear breath sounds in all lobes. Your assessment of the patient, you're breathing fine. But the patient feels like they can't catch their breath. You could have a patient with carbon monoxide poisoning that their pulse oximeter says it's 100%, because carbon monoxide binds much more easily with a hemoglobin molecule than oxygen does. So in that environment, it's going to bind with carbon monoxide instead of oxygen, and their O2 sat looks good. They may stay well perfused looking for a little while, depending on how concentrated that is. So they can be having a lot more distress that we don't recognize because all of our assessments look okay. So don't discount their feeling of distress. They're a little bit ahead of the curve sometimes. All right, we talked about OPQRST. For all of your medical patients, pretty much, you're going to be getting OPQRST. If it's abdominal pain, if it's chest pain, if it's respiratory distress, if it's I feel dizzy, altered mental status, whatever it is, you want to get OPQRST. You need to know these because it's going to help you do a good assessment, but you're also going to have to document this. John, do you need to move? Okay. So onset, when did it begin? Provocation, or I mentioned earlier, palliation. Provocation, what were you doing when this started? What do you think caused it? You know, if I'm having chest pain and I was out mowing the lawn, what do you think caused it? I don't know. I was out mowing the lawn and I just started getting chest pain and I couldn't breathe anymore. What do you think caused it, guys? Probably not out mowing the lawn. He's probably got angina, you know, and his coronary arteries constricted. He wasn't able to get enough oxygen to his heart muscle and he started having chest pain. But yeah, that's going to be a sign of angina. It's brought on by stress or activity. Whereas a heart attack, you can be just sitting up in your chair watching TV. I mean, you could be sound asleep at night when it happens. So provocation, what were you doing when this came on? May give you a tip of the cause. Quality. Now this example here, quality, we're asking somebody with a cough, so we're looking at respiratory distress. Do you have a cough? Are you bringing up phlegm? If you are, what color is it? You know, what does it sound like? How often do you cough? Do you cough in spurts all at once and then you stop? Or are you just constantly coughing every time you take a breath? So tell me about your cough, the quality of it. Radiation. Do you have pain or discomfort in any other part of your body? Sometimes with patients with respiratory distress, their lungs actually hurt. It hurts when they breathe, or not. Find out if they've got pain anywhere else. It's possible that they broke some ribs and didn't even realize it. So does it hurt when you take a deep breath? What does it feel like? Severity. On a scale of 1 to 10, how bad is it? And we talk about pain, and that's a little bit easier to quantify like this. But respiratory distress, a lot of your patients have experienced that before. And so they have something to compare it to. But they know how bad they feel. You know, if they're just like guppy breathing, how bad is your respiratory distress? Pretty bad. So on a scale of 1 to 10, how bad do you feel like it is? Time. How long have you had this feeling? Now, they may say, I felt short of breath for a couple of days, but the acute onset was 20 minutes ago. So you're kind of looking at two different time frames here. Okay, you're going to look at your patient. As I said, one of the earliest signs of a problem, the patient is not breathing well enough, is breathing inadequately, one of the early signs is going to be altered mental status. And that's due to what? What's the H word? Hypoxia, that's right. If you're not getting enough oxygen to the brain, altered mental status is a very common follower of that. What are the three things your brain needs? Oxygen? No, not really well. Oxygen. What's your cells need? Your brain cells need oxygen.
Nutrient.
I'm sorry?
Nutrient?
Not going there. All right, I'm going to tell you so you can remember. Oxygen. Oxygen, water, and glucose. Remember we talked about when a patient gets dehydrated? You remember we've had this conversation before. When a patient gets dehydrated, they not have enough water in the brain, in the cells. They may have enough oxygen, they may have enough glucose, but if they don't have enough water, they're going down for the count. So all three of these have to be relatively abundant. So if they don't have enough oxygen, you're going to notice that because they're going to have an altered mental status. It may be they just feel extremely tired. It may mean they're not thinking clear. They may be lethargic. Lethargy is an altered mental status. You may notice some unusual anatomy. If you have a patient that has chronic disease like COPD, they may be what we call barrel-chested, where over the course of time, as they've had this COPD, if they've had respiratory distress, their chest actually enlarges because they're trapping air in the lungs. So all of it just gets, they gradually just kind of get this barrel looking about their chest because over time they trap air in there. So you may notice that about them, and then you're going to realize or suspect that they have a chronic condition. Your patient's position may tell you how bad their respiratory distress is. If they're laying down talking to you, you know, sitting up like this on a pillow, what's their respiratory distress like?
Not very much.
Yeah, not very much. If they're sitting up like this, leaning over, you know, with their mouth open and nasal flaring, going, how bad is that?
Bad.
Pretty bad. But if they're sitting like this, they still have the energy to hold themselves up. If they're laying in bed, staring at the ceiling with their head on a pillow going, how bad are they? Yeah, so of those three, who's the worst?
Laying down.
Yeah, the laying down guy, because it's very positional. It's much harder to breathe laying down than sitting up. So as long as they can sit up, they're going to sit up. Another thing you might look for is they want to sit and dangle their feet off somewhere. So they'll sit kind of in a sitting position. Just makes it easier for them to breathe. It kind of helps pull open the chest. So know what tripod position is. That's where they're, you know, sitting like a little three-legged stool. Okay, you need to look at their work of breathing. How would you recognize if they were working hard to breathe? That's work of breathing. You might see their neck muscles, accessory muscle use. What else might you see?
Their abdomen.
Diaphragm breathing.
Their what?
Diaphragm breathing.
If you notice that they're getting some abdominal movement when they're trying to breathe, what else would tell you that they're working hard to breathe? Do what? You mean like stridor or something? No, not that.
You mean after what?
They're going, yeah, if you hear them breathing heavy, that might be to indicate that they're working hard. What else? Flared nostrils, body position. Sure, all of that. And of course, if they're laying down and struggling to breathe. Pursed lips, remember I mentioned that earlier? What do we call that? Remember I wrote it on the board? If they're exhaling against pursed lips like that, remember I wrote it on the board, what is that? Auto-peak, yeah. So they do that technique. It increases the pressure in the lungs, which then keeps the alveoli open, which is good. If they've got fluid or mucus buildup in there, by doing that, it kind of helps move the fluid back across the capillary beds, but it just helps their alveoli stay open. Notice how many words they can say in a sentence without stopping to breathe. That would indicate to you that they're working hard to breathe. Other things, skin signs. Look at their skin. You're going to see a lot of sick people out there, especially with the state of health care and the state of the economy right now. People are not going to the doctor. They're staying home. They got a $30 or $40 copay, or they don't have any insurance. They can't afford it, so they're not going. So you're going to see a lot of bad stuff out there. But look at their skin signs. Skin tells you everything. If they're really pale, then they're probably not perfusing well. If you notice they're cyanotic, kind of blue tinge, they're not breathing well. Look at edema. You can see here, this is pitting edema. They've pushed the thumbs on the feet, and a little depression remains. That's pitting edema. That means that edema is set in there and it's big. You push on it and it stays. Never good. So pedal edema is located where? Yeah, in the feet, yeah. Sacral edema is where? The lower back. So which patients are going to have sacral edema? Bedridden patients, right. We call that dependent edema. It's going to form at the lowest point, which would be dependent. Look at your patient. Now, what is it about this guy that tells you he's having respiratory distress? Tripod. That's going to be the main thing. Now, he doesn't really have his mouth open, but if they've got their mouth open and their nostrils going, they're breathing hard. But the things you're going to look for, airway sounds. Does it sound like he's got an airway blockage in there? Do you hear mucus when he breathes? Do you hear rales or rhonchi or stridor? Do you hear wheezing? You're going to look at the lips, the ears, the nails. Is he cyanotic? Are you noticing any intercostal contractions in here? Any sternal contractions where he's trying to breathe? What else I got in here? What does he report? Does he have tightness in his chest? Does it hurt when he takes a breath? Okay, noisy breathing. Noisy breathing is going to be stuff that you can hear. Oftentimes you can hear your patient breathing from several rooms away. You walk in the house, you don't have to ask where the patient is. You just follow the wheeze or the other airway sounds. So sometimes it's audible and you can hear it. But sometimes, other times you won't hear it until you auscultate. So if you can hear it audibly, that's even worse. So audible wheezing is heard without a stethoscope. Gurgling, what does that indicate? Fluid in the airway. That's going to be upper airway. How do we fix that? Suction. Every time. Snoring, what's that? What causes that? The tongue. You've got the tongue blocking the airway. So usually this patient's laying on their back. The tongue is falling back. Can you swallow your tongue? Only if somebody cuts it off. No, it's attached. It's not. You can't swallow that darn thing. But it can fold back and block the airway. Crowing, what's that? Yeah, I don't know either. Stridor. I do know stridor. Crowing, I don't know. I've never heard it. I don't know. They always say crowing. I've never heard. What does a crow sound like? Oh, oh. I don't know. Stridor. What's stridor?
High-pitched sound.
Yeah, it's a high-pitched sound. It's going to be
Upper airway.
it's upper airway. It's going to be around the larynx or higher. So yeah, it's upper airway, usually due to swelling or blockage. It's some type of something interfering with the movement of air in there. Where is wheezing located? Where is it? Upper airway? Lower airway. Wheezing is lower airway, so it's going to be in the lungs. We'll talk about that more in just a minute. Okay, so when you're auscultating, you want to make sure you auscultate all the lung fields. Both sides, compare them. Do they sound equal? Are they equal? That's one of the things that we're looking for. Listen on the back. Listen along here. What do we call this area? Yeah, mid-axillary. This is the axilla, it's the armpit, so this is mid-axillary. So usually these areas are a lot thinner, so you can hear better if you've got a heavy patient. You can listen above the clavicle, I mean not above the clavicles, but above the scapula in the back, you can hear well. Below the scapula, down here, you can hear well. So get in the habit of listening to all the quadrants, front and back. If you have a choice, you got to listen quick. I'm going to listen at the back. You're going to hear better than listening at the front. You want to listen to them breathe in and breathe out. Because sometimes you may have a patient with just inspiratory wheezes, whereas when he breathes in, you hear wheezing. When he exhales, you don't hear any wheezing. So you need to be able to hear that in and out. Has everybody heard some good, healthy breath sounds out there somewhere? Yeah, if you can't recognize good, healthy breath sounds, you're not going to be able to recognize absent breath sounds or breath sounds that are not healthy. So always listen to all of your patients' breath sounds. When you're out on the ambulance, when you're in the ER, every patient you come in contact with, would you mind if I listened to your lungs? They don't care. Listen to them. Listen in all the quadrants, just don't make them short of breath doing it. Wheezes, high-pitched sound created when the air is moving through narrowed airways. When it's moving through the bronchi and it's narrowed, that's where you're going to hear that wheezing sound. Narrowed air passages. Crackles. This is another term. We've got crackles. We've got rhonchi. Crackles are a fine sound. I played these the other night, one night. I'll play them again if I get it to work. Fine crackling sound caused by fluid in the alveoli. Sometimes you may even hear it as the alveoli are opening and closing because it got fluid in there. It makes the sound a little bit more noticeable. It accentuates the opening and closing. Rhonchi, I guess, another word for crackles, and I want you to know it, is rails. You're going to hear both of these used. For some reason, about 5 years ago, they quit calling them rails and started calling them crackles. Crackle describes the sound a little bit better because it's kind of a light, crispy sound, which is going to be the sound you get when there's just fluid in there, like, water kind of fluid. Whereas rhonchi is going to be a low sound that has more of a vibration to it. This is due to thicker secretions or mucus down in the alveoli or in the bronchi. So it's thicker material. So as the air moves through there, it's going to give a deeper sound. So it's like the difference in trying to blow air through milk, through a straw. Did we talk about this? You're blowing into milk versus blowing into a chocolate milkshake. Not just a regular milkshake, but a chocolate milkshake. Kind of bubble, and it kind of has that deeper sound. So those kind of gives you an idea so that you can recognize those different sounds. Stridor, we said, is a high-pitched sound, indicates partial obstruction, either something that's anatomical, meaning it's something that's swelling, or something mechanical, where something has come in from the outside and blocked the airway. All right, let me see if I can play these real quick. All right. We were also going to assess their vital signs, and we look for changes in vital signs. Now, all this is related to respiratory, right? Respiratory distress. You may see an increase in pulse or decrease in pulse. Who are we more likely to see a decrease in pulse? Little kids, that's right. You'll notice a change in their respiratory rate. It usually gets faster before it gets slower, right? Changes in rhythm, very unlikely, but it does happen. Your patient may be hypertensive. They may be hypotensive. Respiratory problem is you don't see it so much in blood pressure changes typically until they start doing very, very poorly. You'll check the O2 sat, your oxygen saturation. Okay, any patient that has inadequate breathing, we're going to have to provide adequate breathing for them, or adequate respiration. So make sure that they are ventilating or breathing adequately. If it's not adequate, you're going to have to fix it. If breathing is adequate, and one other thing has to be in place, we'll put them on a non-rebreather. If they're breathing adequately, all right, put the pulse ox on them. If they have 98% no respiratory distress, are we going to put them on a non-rebreather? If they are having respiratory distress and the pulse ox is 96, what might you do?
Put them under breathing.
Or put them on a nasal cannula, maybe. Those are some of the decisions that you'll have to make. Usually we don't give them oxygen unless their O2 status below what? Yeah, below 95. Or if they have respiratory distress. So we'll just determine how bad their respiratory distress is. You know, if it's like, oh, I feel like I can't really get a good breath today. I just don't know what's going on. How bad is my respiratory distress? Not too bad. But if I feel like I have respiratory distress, might put you on a cannula. Otherwise, we're probably going to put them on a non-rebreather. Put them in a position of comfort. You know, if they're more comfortable sitting up, then you want to prop them up sitting up. If they tell you to lower the head back, fine. Whatever position it takes so that you're the most comfortable as you try to breathe, we want to get in it. If they have a prescribed inhaler, you want to ask them, do you have a prescribed inhaler? If they do, you want to see if they meet the other parameters so you can assist them with that. At this time, the EMT level, you don't do CPAP, but I'm hoping it's coming so that you can do it. CPAP is continuous positive airway pressure. You're going to need to know this because it is in your curriculum for EMT. So CPAP. You got one? Use it at night? Scare everybody off? You don't have to worry about anybody breaking in, do you? Yeah. Okay, CPAP, the way CPAP works, and remember I talked about auto PEEP a little while ago? This is PEEP, but it's not auto. Auto means we do it ourselves. It's not automatic. So with CPAP, you're actually blowing air into the lungs, continuous pressure in there, which keeps the alveoli open. That's why we use it. So it blows oxygen at a very low level into the lungs, and it splints the alveoli open, or keeps the alveoli open. It also does some other things. Like, see, normally when we breathe, when we exhale, we remove enough of the pressure from the chest that the alveoli kind of close down a little bit, and then when we breathe, they pump up. You know, they smile, and then they go back down. So they're open and closing all the time. When we use CPAP, it keeps the alveoli open, and they don't close. And there are times where that's really important that we provide that for a patient. The main reason, one of the main things that it does, is it, with that pressure, it forces the fluid back across the capillary beds. So it actually moves fluid out of the lungs, away from the alveoli, across the capillary beds, and then it's going to get back into the circulation. So it kind of moves that fluid out. That's the main reason that we use it. We use it most commonly in pulmonary edema because it helps force that fluid out. Indications for CPAP. Pulmonary edema. If you have a patient that's a drowning victim, we may use CPAP. It helps move that fluid out. And it helps splint the alveoli open so that you can oxygenate them better. Asthma patients, COPD patients, we're going to use CPAP. Really, we use it for just about any patient who has some serious respiratory difficulties. And I can tell you that CPAP has saved many, many people. We talk about this at length if you move on up through advanced and paramedic. But there are some contraindications. Not too many, but there are some. Think about what they could be. When would you not want to be putting a constant flow of oxygen into a patient's lungs?
Chest pounding?
Yeah, which would present in which way? Yeah, if they've got a hole in the lung somewhere and we're forcing air in there, where's it going? You've got on positive pressure, that air's going to go into the lungs and just right out that hole. So now what's the problem? Yeah, we develop a tension pneumothorax, which means there's tension in there. The chest starts getting bigger and bigger. And when you've got air in the chest, what's going to happen? What else happens in there? It's going to put pressure on the heart, so the heart can't fill properly. It can't contract, expand and contract. It's going to put pressure on your other lung so that it can't expand and contract. So it really puts pressure on everything in your chest and interferes with everything that goes on in the chest. So certainly a, let me get there. Penetrating chest trauma, which would be like a tension a pneumothorax. Severely altered mental status. You don't want to use this on a patient that has a severely altered mental status. The best way to do it is have them hold the mask themselves. You want them to be able to assist in their care. If they're not breathing, you can't use this. They need to be breathing. Because all this does is put air in. It's not like we're ventilating the patient. If they are very hypotensive or shocky, we don't want to use this because it keeps the lungs inflated all the time. And if you've got a problem with circulation, we don't want the lungs inflated all the time because when they're inflated, it's always going to put a little pressure on the heart. So you don't want to use it if they're already hypotensive. If they're vomiting, you don't want this mask tied to their face. Upper GI bleeding, you don't want to use this. So these are times that it's contraindicated. You need to be familiar with these because you may see it on registry. If you're unable to get a good mask seal, then it doesn't work. So there's no point in using it. Side effects. It can cause hypotension. Why can it cause hypotension? Yeah, because I told you guys this just a minute ago. The heart can't fill. So if it can't fill, it's going to drop the blood pressure. So that may be a side effect. It can cause a pneumothorax. If you've got a little weak area in the lung, a little bleed. Remember, I think I mentioned that word to you before. I didn't. I am now. A bleed is going to be a little weak area in the lungs. And if you're putting a lot of pressure in there, it can actually burst through that little bleed. And now what have we got? Yep, a pneumothorax. You increase their risk of aspiration with this. I'm not real sure why, but that's what they say. It's very drying to the corneas. You know, if you've got that mask on there and any leakage, it blows into your eyes. Anyway, when you're using this, make sure you explain it to the patient. They're in respiratory distress. That's why you're using it. And you're going, na with this big mask that you put on their face. It's 10 times worse than even a BVM or non-rebreather. When you come at them with this, this CPAP mask, it's pretty substantial. And it can be really scary. So make sure you tell them what you're doing. And you can adjust it. So start it real low. Let them feel it. Just put it on your face. Kind of breathe normally here. And then you can crank it up a little bit. After you see, that's quite substantial, and you're putting these little stretchy bands on their heads. It's kind of scary for them. After you put it on, leave it on for a few minutes, start reassessing them. Is their mental status getting better? Are their vital signs improving? How about their difficulty breathing? On a scale of 1 to 10, how are you doing? Auscultate their lungs. If it's starting to move that fluid out, hopefully you're going to notice a clearing of the lungs. If they get worse, which happens sometimes, you can't fix everybody, you want to remove it and start ventilating them. So sometimes the CPAP is something you'll use between a non-rebreather and ventilating them. The CPAP may fix them, so make sure you give it a shot when you guys get the opportunity. Okay, what time is it? We're going to move into respiratory conditions, and we've got quite a few of them. Y'all want to take a short break before we roll on? Okay, let's do that. Just 5 minutes. You don't need to go anywhere. Okay, respiratory conditions. This is where you're really taking notes. We weren't taking notes before. I know you're taking notes now. All right, COPD. What's the most common cause of COPD? If you've ever known anybody with COPD, I'm telling you, you do not want to be a cigarette smoker. When we say COPD, chronic obstructive pulmonary disease, can also be diseases. This is several diseases rolled into COPD. Because the presentations are similar, our treatments are similar, the actual cause of the problem is fairly different. So when we talk about COPD, we're talking about emphysema, We're talking about chronic bronchitis, black lung. We don't see much of that down here. But so there's several, it's not just one or two diseases, but a lot of them will come up under this COPD heading. Overwhelming majority of cases are caused by cigarette smoking. Okay, chronic bronchitis. Now notice it says chronic bronchitis. How do you go back?
I was writing down those.
Okay. Chronic bronchitis is different than the bronchitis you get once a year or once every 2 or 3 years. Chronic meaning it repeats itself. For them to put it in the chronic classification, it usually has to be present for 3 months or longer and occur on a regular basis. So if you've got bronchitis, it doesn't go away, you've had it for 3 months, 6 months, it doesn't go away, they're going to start calling it chronic bronchitis. In this case, your bronchi and your bronchioles are chronically inflamed. They're just always irritated. And one of the reasons that they're always irritated is, as part of this disease process, the lungs create a lot of mucus. Mucus interferes with good gas exchange. So when you get an excess of mucus that's built up in the airways, as you can see in the picture here, it's going to interfere with your breathing. This is normal. You get all that crud in there. It's almost like arterial sclerosis or something. It kind of builds up in there. So as the mucus builds up, it interferes with gas exchange at the cellular level. You can't get good air down into the alveoli. We see an excess mucus buildup also with our asthmatic patients. It's not just with bronchitis. Just another picture, you can see all this buildup in the bronchioles and the alveoli. So it interferes with gas exchange. With emphysema, this is a completely different disease, but the signs and symptoms are very similar. As I mentioned before, how we get there is a little bit different. With emphysema, the walls of the alveoli are actually destroyed. In a normal process, if you think about it as like a clump of grapes, what would you call them? What do you call them? Clump of grapes? A what? Cluster. Yeah, thanks. A bunch, a cluster of grapes. Yeah, each grape has skin all the way around it, and they all come together forming this bunch. With emphysema, the skin around each little grape is destroyed. As you can see, we don't have little clusters like you see here. They are destroyed and they just kind of lose their form. So you lose a lot of surface area. You know, gas exchange occurs on the surface of the alveoli. Well, if the surface areas are destroyed and they, instead of going shaped like this, it becomes just one giant grape, then you're losing surface areas. That makes sense? A whole clump of a cluster of grapes with all of their surface area, if you peeled all those and spread it out, you're going to have a whole lot more surface area for gas exchange than if you have just one big grape. Does that make sense to you? So it loses surface area. That's the biggest problem here. The lungs lose their elasticity. That's the whole lung tissue as well as the alveoli themselves. It's not able to expand and contract. This is where some of that barrel-chestedness comes from, because they get air in there and it can't be, you can't squeeze it out. You know, if you've got air in your lungs, how are you going to get it out if it's not going normally? You're going to go, you have to squeeze it out sometimes. Well, with these patients, they having to squeeze it out all the time. So that's why you see that pursed lips. They go like that because they're having to create their own positive end pressure going and squeeze it out because it gets trapped in there because of that loss of elasticity. Does that make sense? So we get air trapping and it interferes with normal breathing because you don't get that normal inspiration and expiration. They breathe in and it doesn't go out. So they have a whole lot more dead space in their lungs than we do. So they chronically have much more carbon dioxide in their lungs than we would because it remains in dead space. It doesn't go in, it doesn't go out, we don't get new oxygen. It just stays in there and gets really nasty. Also in emphysema, you're going to see a mucus buildup. Usually it's going to be in the bronchial trees, but here this yellow indicates the trapped air. But see the shape of the alveoli here? The walls have broken down. Instead of having those nice little round shapes, it just deteriorates into just this one giant wall. So, go back. So air gets trapped in here and that you have a hard time getting it out because there's no elasticity there. The lungs can't compress to squeeze it out. Also, you see bronchial spasm with emphysema. The bronchioles will actually tighten down and spasm. So it's like you didn't have a big enough problem with trapped air in here. Now the bronchioles are spasming closed and they have a really difficult time breathing. So emphysema is not good either. Okay, asthma. This is really the third one in our triad when we talk about COPD. Does anybody have any asthmatics in your family? Not too many. Usually about half the class raises their hand. But yeah, asthma, we usually think of it as an episodic disease. You know, you may have a couple of asthma attacks a year or once a month or once every few years depending on the patient. So it may be episodic, but we group it into COPD because the presentations are similar. We term it a chronic disease. Now, sometimes you'll hear of children that have asthma and they outgrow it. But usually when it goes through childhood and into adulthood, it follows in their whole life. It's a chronic condition that some people do outgrow. So during an asthma attack, the small little bronchioles will narrow down. They will spasm closed also, all that bronchial constriction. And as I mentioned before, asthma also produces excess mucus in there. So now they've got bronchial constriction, bronchial spasm. They also have a buildup of mucus. What does that sound like? Our other COPD diseases, right? So the presentation is similar. Also with asthma, they tend to trap air in their lungs also, just like our other air trapping diseases. Which one was that? Which was the air trapping disease we just looked at? Emphysema. That's right. You're paying attention. I like that. So your asthma patients get a buildup of mucus. They have air trapping. They have constriction of the bronchioles. So it presents like the other COPD. Now, in the beginning, the early stages with asthma, the airflow is constricted only in one direction, meaning when they try to exhale, they're exhaling against those closed bronchi. But as it progresses and gets worse, as the asthma attack worsens, they may get to where they're having wheezing in both directions. They have difficulty inhaling and exhaling, or exhaling and inhaling, if you will. In the inhalation, the lungs are exerted outward, pulling the diameter of the airway and allowing airflow into the lungs. So inhalation is easier for them because of the mechanical process of breathing. You know, as they exhale, the muscles tighten. It also pulls out the bronchioles, so it's easier to breathe in. Once all that relaxes, it's harder to exhale against those closed airways. And then because of that, the air becomes trapped in the lungs. We see that air trapping more commonly with pediatric patients. But one thing that you'll see with a pediatric patient that we don't see usually with our older patients is they do their auto-pee. And little bitty kids will grunt, but as they get to be 4, 5, 6, they'll cough. If you think about what a cough is auto-pee. It increases the pressure in the lungs. It also helps them to force that air out. So little guys, during an asthma attack, you may hear them coughing as they're trying to split open their alveoli. Asthma, as I said before, you've got a buildup of mucus. That dripping looks really sick, doesn't it? But you also see how they've shown this constriction of the muscles around the bronchi. They constrict. If you think about the causes of asthma, probably one of the most common causes is going to be stuff in the air. You know, they're going to breathe in something that they have sensitivity to. So one of the ways the body combats that is bronchial constriction, to keep those nasty stuff out of the lungs. Well, it also keeps the air out of the lungs. So, y'all okay with asthma now? Writing all that down. Pulmonary edema. We know pulmonary is lungs. Edema is what? Fluid, yeah. Fluid in the lungs or swelling. So with pulmonary edema, we've got an abnormal accumulation of fluid in the lungs, particularly around the alveoli. If you have just a little bit of fluid in the lungs, where is it going to be located? The bottom, because why? Gravity. Yeah, so if you auscultate and you hear, fluid in the lungs down low and they're clear up high, I feel a little bit better, right? If I hear fluid in all quadrants, how do I feel? Ooh, not good, because it's, fluid's filling up. Yeah, it's like the difference in a Coca-Cola that's full and a Coca-Cola that's only got, 20% in it. We see pulmonary edema a lot with our congestive heart failure patients. If a patient has congestive heart failure, it's not uncommon that they have pulmonary edema. What exactly is congestive heart failure? Something's congested. Yeah, I never have really completely figured out the term. Congestive heart failure doesn't make a whole lot of sense to me. A patient with congestive heart failure typically has got damage to the heart tissue. It doesn't contract like it's supposed to. It may just have a small area that doesn't contract. It may have dead tissue all the way around, so it's not able to contract, get a full contraction. So it's not ejecting all that blood. So stuff is going to back up. Right? Does that make sense? Which chamber of the heart is going to be most prone to tissue death? It's going to be the left side. So if the left side of the heart backs up because it's not able to inject all that blood, more comes in, but more is not going out because it can't eject it, where's that going to back up to? The lungs. The left side of the heart backs up to the lungs. So you may have left-sided heart failure, which is what most people generally have. That's congestive heart failure, meaning that ventricle is not pumping well. So the blood backs up into the heart, backs up into the lungs, which then it separates and it causes pulmonary edema. So when you've got fluid backed up in the lungs, the patient can't breathe well, right? Respiratory distress. So if I tell you the patient has congestive heart failure and they've got fluid in their lungs, you're going to expect that it's a problem with the left ventricle. If I tell you that they have pedal edema, fluid down at the ankles, and some respiratory distress, say, where's the problem in the heart? The right side, because the right side of the heart is going to back up through the systemic circulation. So if the blood can't go in, it's got to come somewhere. It's going to go, gravity's going to take it down low, and instead of just sitting there and coagulating, it's going to separate. So it's going to move fluid out into the tissues. Now you can have both right-sided and left-sided failure. If the left side's failing, eventually the right side is going to fail as a consequence of that. As it backs up into the lungs, it's going to back up into the right side, which is going to back up throughout the body. So you may start out with with left ventricle damage that's going to cause right ventricle damage. Okay, pulmonary edema, as I mentioned, that pressure just builds up in the capillaries and it separates. Fluid crosses and accumulates in and around the alveoli. So the fluid stays pretty much more often in the alveoli and the lung side, and the blood moves on. It gets kind of thick though. Because of that fluid that gathers around the outside of the alveoli, I think I have a good picture in here. That little bitty, diffusion causes the carbon dioxide and waste products to move into the lungs and allows it to pick up the oxygen. That occurs by diffusion. but they have to be side by side in order for them to diffuse across those membranes. Well, if you've got fluid in there that separates your capillary beds from your alveoli, can't diffuse right. So they're not getting oxygen. They're not getting rid of waste products. That's what's happening with pulmonary edema. So now the patient feels like they can't breathe. It hurts when they breathe. They can't get a breath because they might be getting enough air in, but it's a problem with the diffusion. It's not able to get across that fluid to get into the capillary beds as the blood's returning from the rest of the body. Does that make sense? Yeah, I don't know. I'm not sure you get it. Okay, signs and symptoms of pulmonary edema. The patient reports they have difficulty breathing. Dyspnea is difficulty breathing. What is nocturnal dyspnea?
People breathing while they're asleep.
Yeah, while they're sleeping or at night when they're in bed. Why does pulmonary edema get worse when they're in bed at night? Why does it occur more when they're sleeping?
Laying down.
Yep, when they're laying down. When I'm sitting up in the middle of the day and I've got pulmonary edema, I've got all of this clear space with alveoli that are not affected. So I've got 2/3 of my lung that I'm still using to breathe. When I lay down at night, really half of my lung tissue is covered. So daytime, gravity takes it down and cools it. Nighttime, you're laying like this, and couple that with the pressure on the top of your chest just from tissue and muscles, it really compresses it down and it decreases your surface area in which to exchange oxygen. So yeah, they're going to have a much worse time at night when they're laying down. Your patients with congestive heart failure, when they sleep at night, more times than not, they're going to be propped up on 3 or 4 pillows. These are the people that sleep in the lazy boy at night. I mean, I can't tell you the number of times I've gone in for a cardiac arrest and the guy is in a lazy boy. And I'm thinking, God, that seems really weird. But it's not weird. They've got a lot of pulmonary edema. They breathe better when they're laying down like that. I mean, when they're sitting up. They're going to be anxious. Why are they anxious? Can't breathe. It's going to make me anxious. That's also going to be a sign of what? H word. Hypoxia. Exactly. Once you start getting hypoxic, you're not getting enough oxygen to the brain, you're going to see altered mental status. Anxiety is a form of altered mental status. There. Pale, sweaty skin, cool, pale, diaphoretic. You look at them, they look pale, they're sweating it up. Tachycardia, very common. Why do they become tachycardic? Yeah, compensate for what? Compensate for breathing? You're going to have to try a little bit harder here. Why are we tachycardic? This goes back to about the first week of school. Yep, the heart's trying to pump faster to circulate oxygen. There's not enough oxygen in the blood that's there, so we're just going to send it around faster and maybe we can get more oxygen out everywhere. It's not real effective, but they become tachycardic. That's why you see tachycardia during shock. You know, the blood pressure drops, we're not able to perfuse, don't have enough oxygen, you become tachycardic. Sometimes they may be hypertensive, which has to do with a whole different ball game that we won't go into. But you may see them with hypertension. And they will almost always have a low oxygen saturation. You know why that is? Remember I explained to you about the fluid around the alveoli? They're not able to exchange gases very well. So they're going to build up carbon dioxide, and not a lot of that oxygen is able to cross that fluid barrier. So they are chronically hypoxic. And that's important, and I want you to remember that because we'll talk about it more. Common symptoms of pulmonary edema. When you auscultate, you're going to hear that fluid in their lungs. You're going to hear it either as rails or crackles. That's going to be the less bad. You may hear wheezing in there. You may hear rhonchi. So you're going to hear, it was pretty severe, you're going to hear a lot of ugly breath sounds. Now, with your pulmonary edema patients, it's not unlikely for them to cough up some kind of pink, frothy sputum. That's going to be from the fluid in the lungs, and it's so irritating that it causes those alveoli to bleed. The tissues in the lungs actually bleed. They don't usually cough up bright red blood. It's mixed with all that fluid, so it's kind of pink and it's kind of frothy. Once they're coughing up this pink-tinged, frothy sputum, they are doing very, very badly. Very, very badly. Treatment, we're going to treat them just like we would any other patient with inadequate breathing. If you're working in a service that allows you to use CPAP, that's where you're going to fix. If you're going to fix these patients, you're going to fix them with CPAP. So if you have the ability to use CPAP, you want to use it. If you're not able to carry it on your trucks, you need to be calling for ALS because somebody needs to put these patients on CPAP. Now, outside of that, you don't have CPAP available to you, you're going to put them on high concentration oxygen. One advantage of bagging them is that pressure. When you're bagging them, you're forcing higher pressure into the lungs, and that helps move that fluid out. Is it going to freak your patient out? Yes. But you'll be surprised the number of them that have been ventilated before while they're conscious, and they know that it helps them. So make sure you explain it to them and say, this may actually help you. Work with me here. Put them on high concentration of oxygen. Keep their legs down if possible. If you can ventilate them while they're in a semi-Fowler's, leaning their head up against the back of that, if you can ventilate them like that, you want to do it. It's going to be better for them. And then CPAP. That almost looks like C-crap, doesn't it? I got to look. Okay. Might it be possible for a patient to have multiple respiratory diseases?
Yes.
Absolutely. Could a person with underlying COPD also have pulmonary edema? Yes. If you've got chronic lung problems, it's eventually going to lead to cardiac problems. Okay, pneumonia. Pneumonia is not one of our COPD diseases, but it is something that you see very commonly. You can get pneumonia from a virus, a bacteria, or even from fungi. So there's a lot of different ways that you can get pneumonia, a lot of different forms. Very commonly it comes from inhaling those bacteria or virus. Well, microbes grow in the lungs and it leads to irritation, inflammation, and disease. Signs and symptoms. Patients are going to feel short of breath with and without exertion. Either way, they can have it. They commonly cough with pneumonia. Most of the time they're going to have a fever. They may have chills, that come with the fever. One caveat here is your elderly patients very commonly can have pneumonia and not have a fever. I can't remember if we've talked about this before, but once you get on either extreme, very, very young or very old, we have problems with thermoregulation, and their bodies may not be capable of causing a fever. They may chronically have a body temperature of 96 degrees, and you check their temperature and it's 98. Well, that's a 2-point fever for them, but we see it as normal. So you could have elderly patients or very young patients that would normally be feverish, except they're not able to produce a fever. So don't discount pneumonia in your elderly patients just because they don't have a fever. But for everybody else and half the older people, you're going to see a fever with pneumonia. Because, why? They've got an infection going on. I mean, they've got something going on for sure. Now, they frequently will report chest pain, but usually it's going to be a sharp chest pain and pleuritic. What exactly does pleuritic mean? If I said the patient had pleuritic chest pain.
Only happens when you breathe.
Yep, exactly. And it doesn't really fit the word when we talk about plural. But yeah, it only hurts when they breathe. If they sit quietly and not breathe, then they don't have the chest pain. But when they take it hurts to breathe. It's just like having broken ribs. Do you have a question, Megan?
When I had walking pneumonia, mine, it would just be sporadic. Like the sharp pain was like right here, and it would hurt until I went and laid down, like on my back.
It was positional? A lot of it?
Like it would just happen. Like I could be just doing nothing, watching TV, and it happen, and then
And it
I'd
start
lay
hurting.
down.
Yeah. How long before you were diagnosed?
I had it for several weeks before
Before
anybody
you-
ever took me to the doctor.
Yeah. Weird. Sometimes they'll report a headache with this. I'm not sure why. And you may notice they're pale, cool, diaphoretic. We've talked about diaphoretic, right? You know that sweaty when it's not hot outside. And fatigue. Fatigue is very commonly associated with this. They're not getting enough oxygen. You know, they're hypoxic. It's going to make them feel very fatigued and tired. And why would they be confused? Because they're hypoxic, yeah. And confusion indicates what? Altered mental status, yeah. Okay. Treatment. Our treatment for somebody with pneumonia is going to be mostly supportive. We're going to give them oxygen if it's indicated, transport. If they're breathing inadequately, we know how to treat that, right? We can recognize inadequate breathing. We know what to do. Okay, next on your little note card, spontaneous pneumothorax. Who can tell me what that is? Yeah, you just drop a lung. You just sitting there and all of a sudden, bam, that one's gone. Spontaneous pneumothorax. Spontaneous means what? Yeah, it's really almost like idiopathic, meaning, you have a question, John?
I was just gonna say something. How much more haven't happened 3 times?
Yeah, if you've had one, it's much more likely to have another one. You've had them yourself, is that what you said, Kirsten?
No, I know someone that had just died from a funeral was just past weekend.
From a spontaneous pneumothorax? Did both of them drop? Oh, yeah? Hmm. Or they have other respiratory disease?
I'm not sure.
Yeah.
Just kind of,
Yeah, spontaneous pneumothorax. Spontaneous usually means that it happens. It's not like somebody kicked you in the chest, you know, you took a bullet or something. It just happens and it's like, gee, why did that happen? So that's what spontaneous pneumothorax means. Lung collapses without injury or other obvious cause. Now we see it in certain groups of people. Heavy smokers, regardless of their age, are much more prone to spontaneous pneumothorax. We also see it in tall, thin, young people frequently. It presents commonly with Marfan's disease, which is a connective tissue disease. But we see Marfan's in, they say that Abraham Lincoln, the president, had Marfan's disease. And if you looked at him, he was very slender, he was very tall, very lanky, but his arms actually were longer comparatively than other people. So we see spontaneous pneumothorax commonly in this population. But if you're doing an interview with a young guy that tells you, you know, I can't breathe, it hurts when I take a deep breath, you know, you auscultate, and you're pretty sure he's had a spontaneous pneumothorax, you want to ask him, do you smoke a lot? And you'll be surprised more times than not, that's going to be one of the risk factors there for him. Signs and symptoms. You can figure these out. Sharp pleuritic chest pain. It's a sharp pain. It hurts when I try to take a breath. It's not like pressure on the chest. When you auscultate, they're going to have decreased lung sounds. Now remember, I think I drew up here one day that you can drop a lobe of a lung and not drop the whole lung. When I say drop, I mean have a collapse. So depending on the size of the hole, if it's a very small hole, you know, like a half a centimeter, then it may fix itself. So they may just have a little bit of air that's going out, and they may just lose a small collapse of that tissue. It doesn't collapse the whole lung. But as it gets worse, it may gradually collapse the whole lung if it gets worse. But generally speaking, the very small ones will be self-healing, and there's not a lot you can do for those. But you'll auscultate all around the lungs to determine, you know, if you hear equal sounds up here, equal here, but you listen low and you hear it on one side, not on the other, then hopefully they've only lost a small portion of that lung. They will usually have shortness of breath, and certainly shortness of breath and difficulty breathing when they exert themselves, because the lungs just can't keep up with the requirement. If you check their pulse ox, you know, if they're only breathing on one lung, their pulse oximetry reading is going to be less. They may even be cyanotic. So it can be a wide range of presentation. You can have somebody that's just lost a little lung tissue from a little small pinhole in the lung to somebody that's had a blowout in the lung. And every time they take a breath, that air is rushing into the chest. They're usually going to be tachycardic just because they're hypoxic. The blood pressure tends to drop, particularly as that pneumothorax develops into a tension pneumothorax, which we'll talk about in a minute. Treatment for spontaneous pneumothorax, all you can do is transport them. These patients may require a chest tube when they get to the ER to reinflate the lung, take the air out of the chest. You're going to provide oxygen. Do you want to use a BVM unless it's absolutely necessary? No, you don't want to continue to pump air into the chest. It's never good. CPAP, why would we not use CPAP? Yeah, blowing air under pressure into the chest. That's never good. Okay, next, pulmonary embolism. What's a pulmonary embolism?
Why?
It's a what?
Step in the lung.
Yeah, emboli is going to be a blockage, something that's moved through the vascular system and lodges in the lungs. A blockage in the arterial blood supply to the lungs. It could be a blood clot. It could be some fatty tissue. It could be anything that's entered into the vascular system. We see these very commonly from a deep vein thrombosis, DVT. DVTs usually develop in the lower legs. It can occur from a lot of different things. A patient that, say you flew across the country, you flew for 6 hours from San Francisco to Atlanta, and you didn't get up a single time. Well, you kind of interfered or impeded the blood flow from your extremities back to the heart. And so when the blood's not flowing real well, what happens? Yeah, it clots. So you develop a clot and it moves to the lungs. That's what a deep vein thrombosis is. And we talked about this before, I'm pretty sure, about history. If you think somebody's had a pulmonary embolism, they tell you that, yeah, they just flew across the country and sat for 6 hours, you would suspect this. What other risk factors can you think of?
Plastic, when your legs in a cast.
Yeah, if you've got a broken leg and you're in a cast, you're immobile. We see this with cancer patients, very ill patients that are bedridden. They can't get up and move all their blood around, so they're much more prone to blood clots. So pulmonary embolisms most commonly are going to be from DVTs, where somebody, they say throw a clot where they've been immobile for a long time. Increased risk from limb immobility, local trauma, or if you have a condition where your blood just clots fast. We see it, it's not uncommon in pregnancy. I guess we were talking about to the other class recently. When a woman is in late pregnancy, her body's getting ready to deliver that baby. And one of the things that it does a whole bunch of things, but one thing it does is it thickens the blood a little bit. Because when that baby is born, it's not abnormal, for the mother to lose about 500 cc's of blood. But the body acts to clot that off. So near delivery and just after delivery, the blood is more prone to clotting. So it's not unusual for a woman to throw an embolism, throw a clot near delivery, during delivery, and after, up to several weeks after delivery. It's one of the processes of the body so that she won't bleed to death during delivery. So we see it common with pregnancy. I mentioned cancer patients and immobile patients. So signs and symptoms, you almost can't tell this from a spontaneous pneumothorax in the signs and symptoms, except for one thing. How will you be able to tell the difference?
When you auscultate.
Yeah, when you auscultate. When you auscultate, if they've dropped a lung, you're going to know it. They're going to have chest pain. It's going to be sharp chest pain. They're going to have shortness of breath because you've got a clot. That clot can lodge, if it's a large clot, it may actually, include more tissue there. So there'll be shortness of breath. They're going to have low O2 sats. They may be cyanotic, depending on where that clot is lodged. Tachycardia. You may hear some wheezing associated with this. Our treatment, let's see. We may have difficulty actually diagnosing a PE, call it PE, pulmonary embolism in the field. It can look like a lot of other things. But we're going to transport them. How do you think they're going to manage this? Yep, they're going to have to give them some kind of blood thinners and hope they can break that clot up. But this is one of those things that if a person throws a big enough clot, they're just dead right there and there's nothing you can do about it. I've read many times about somebody that's been in the hospital and they're being, released from the hospital that day, and they get up on their crutches and, they just keel right over it, and they're dead before they hit the ground, pretty much. But if you're fortunate enough that the clot's small enough, they're going to have respiratory distress, you can get them to the hospital and they can take care of it, hopefully. You're going to provide oxygen for them and rapid transport. That's about all you can do. If it gets bad, if they have inadequate breathing, then you may use your BVM and bag them. Okay, next disorder, epiglottitis. That is a big word, right? Epiglottitis, that means that it's a very serious condition. Epiglottitis can kill your patient. We see it much more commonly in children than adults, or traditionally we've seen it more commonly in children than adults. Now we're seeing it a little bit more commonly in adults and children because now they have a vaccination. It's not for epiglottitis, but it's for one of those things that kids get. We take immunizations for everything now. Anyway, with epiglottitis, you know what epiglottis is. That's the little flap that covers the glottic opening. It's an infection really of the glottis and the tissue around it. So I don't want anything swelling around the opening of my airway. How about you? If that flap that goes up and down now gets swollen and gets really fat and full of edema and it can't flap up and down, what's going to happen to me? It'll suffocate. Yeah, it's not a good thing. It's a bad thing. So when it's really severe, it can actually occlude the airway and there just really isn't anything you can do about it. Pretty bad. We see it usually in older children over 4. And if you remember, it's a big word, bigger people, worse condition. Signs and symptoms. I'm going to make a chart here, I think, because I like charts. I draw so good. That's a big one. Okay, epiglottitis. This other one is crude. These are mostly childhood diseases, but I said we are seeing epiglottitis more with older kids. So with epiglottitis, one of the things you'll see is drooling. Think about that.
So
How many?
common children?
Yeah, more common. Croup we do see in kids a lot. We used to see epiglottitis more in kids. As I said, we're seeing it more in the adult population, so it's not purely a childhood disease anymore. But epiglottitis is one of the things, the hallmarks is going to be drooling. Think about how many times you swallow in 60 seconds. Just sit there for 60 seconds, sit forward, and don't swallow. I'm watching it. Do not swallow. Don't swallow. That means don't anybody swallow. Don't swallow. You're busy not swallowing, all right? Starting to get wet in there? You're not swallowing, all right? Starting to choke to death? Y'all not swallowing over there, are you, Emily?
My mouth strikes.
Yeah, well, don't swallow for a while. Starting to get full in there? Getting kind of swampy? After a while, why don't you swallow? Because I told you not to. People with epiglottitis, if you think about that epiglottis being swollen and infected and sore, when you swallow, it hurts. So they're not going to swallow. So they're going to sit forward and they're going to start drooling because it hurts too bad to swallow. So that's going to be one of the things that you'll recognize, one of the signs with epiglottitis. It hurts to swallow. They're going to be sitting in the tripod position because they don't want to drown on all that spit. You're not spitting on each other back there, are you? Start drooling on your page. You know, I'll swallow now. I don't want to see like that. I don't want to see that. So they're usually going to be sitting up and they're going to be in tripod position because they don't want to swallow. If they're sitting back, you try to drool while you're sitting back, you're just going to die. So they're going to sit forward and they're going to drool it out. They look sick. They look like crap. It hurts to breathe. It hurts to swallow. They're not doing any of that. They look sick. They are sick. They have a serious infection. If they try to talk, it's going to sound really weird because, you know, when you're breathing, we speak because the movement of air through our vocal cords. If that epiglottis is swollen in there, we're not going to move a whole lot of air, and it's going to make a muffled sound because it's got a little muffler over it. Ta-da. Epiglottitis has a high fever. So, high fever. Big word. Very sick. Here, a high fever, we're talking about over 104. It's a major fever. And we're going to hear stridor, typically, which is an upper airway occlusion, right? Something's interfering with movement in the upper airway. So, yeah, we expect to hear stridor. Treatment, how are we going to treat this? Give them ice cream? Here, eat some ice cream, make it feel better. Yeah, there's not a whole lot we can do. You may consider oxygen. It's going to be a rapid transport. But you're going to leave well enough alone. If they're breathing, I'm not bothering them. Keep them calm and comfortable, because if that epiglottis, if it spasms and drops itself right over the glottic opening, what's going to happen? There's no breathing taking place. So we do not want that to happen. Do not look in the throat. If they're drooling, they look sick, they got a fever, don't say, let me look at that. Let me get my little pen light out. Don't do that. Don't even have them open their mouth. If you can put them on high concentration oxygen, fine. If it freaks them out, don't do it. Rapid transport. I don't know if I have croup in here. It should have been next. That's okay. I make it my own. Do what? It's not in the book. I just can't remember if I put it in here because it should have been right here. All right, croup. Let's see. Let me. Age. Yeah, that says age. Okay, with your patients with epiglottitis, they're going to be older. They're going to present with a high fever, and their degree of difficulty or sickness is going to be high. Croup is a very common childhood respiratory disease. Their temperature is usually low, like under 102. It may be 100 to 101. Age, these are usually from about 6 months to about 3 years of age. They're not nearly as sick as one with epiglottitis. This is something they've usually had an upper respiratory, something for a day or two, and it develops into croup. With croup, there's that seal bark sound. I'm sure you've heard it on the internet, or you've heard a kid with it. It sounds like a big fish going hoo, hoo, hoo. As they breathe, it just makes this awful croupy sound. That's why they call it croup. But with croup, the temperature is low, the age is low, they're not as sick. Epiglottitis, temperature is high, they're older, and they're sicker. All right. Next, cystic fibrosis. This is something they just added to the curriculum a couple of years ago. Cystic fibrosis is a genetic disease. It's an inherited disease. And it causes thick, sticky mucus to develop really almost throughout the body. It develops in the lungs, but it also develops in the gastrointestinal system. So it causes problems there too. Mucus in the lungs, of course, is always going to interfere with breathing. But as it builds up in the digestive tract, it also leads to rather serious digestive issues. Signs and symptoms. Now they can have an acute exacerbation also. Just we talked about that with asthma. You may be an asthmatic, you have asthma, but you have acute presentation where that would be where you have an acute asthma attack. Same thing with your cystic fibrosis patients. They may manage their disease relatively well, but they may have an acute buildup of mucus where they actually cough up mucus. They're going to feel very tired because that buildup of mucus, it interferes. It's kind of like the mucus buildup with your COPD patients. It interferes with gas exchange. So they're going to feel very tired. They're much more prone to developing pneumonia because of that. Did we miss something back there, guys?
Ended up with a lot of ink on my hand somewhere.
You know, I was making hot pepper jelly this morning, and I broke my green food coloring. And you can't see it, that's why I'm not wearing a dress today, because I spilled it all over me. But I did get it out from under my fingernails, which was good. So you have ink on you, huh? Ajax will fix that. Took care of my green fingernails this morning. Anybody got any Ajax? Anybody know what Ajax is? Probably not, yeah. Because you don't clean. I do. Okay, your cystic fibrosis patients are more prone to pneumonia. They get infections from all of that buildup of mucus. You'll notice gastrointestinal or abdominal problems. It may be distended because it really acts very dramatically on the intestines. So you may see distension. They may have abdominal pain. They may also cough up blood because of that irritation in the lungs. Pretty nasty. Of course, I would feel nasty if I had all that mucus in there. And they usually are very thin. Any idea why they're so thin? Yeah, their gastrointestinal system, the GI system is just torn up, so they don't manage a lot of food, so they don't eat because it has a bad effect on them. Treatment, all we can do is if they need to be transported, but usually if it's an older patient with cystic fibrosis, they can give you good history. Otherwise, the caregivers will have to tell you how to best manage them. So always ask them. If they're breathing in adequately, what do we do? We're going to have to bag them, that's right, and transport. Now, there are other viral respiratory infections. I'm just going to go through these fairly quickly. Any infection in the respiratory tract, kids get them all the time. Adults get, just some kind of upper respiratory infection. Some are minor, some can be very serious. With your patients with underlying disease, emphysema, COPD, any of those, if they get an upper respiratory infection on top of their disease, they can be very ill. Okay, you know this stuff. You get an upper respiratory, scratchy throat, runny nose, crap like that, fever, chills, can spread to your lungs. As it gets worse, as the infection grows, you may cough up green or yellow sputum. They tell you, they ask you, what does it look like, when you cough it up? If you tell them it's green, then you have an infection. You know that. Okay, quickly we're going to go through the inhaler. All right. And what we're going to go through here, we've gone through the drug and the actions already. We're going to go for how you actually administer this. Now she's self-administering, which is nice. Meter dose inhaler, we call it a meter dose inhaler or MDI because it's going to deliver a specific amount of medication at a time. What the meter dose inhaler does for the patient is it dilates the bronchioles. That's the action. That's why we give it. It dilates the bronchial passages in the lungs. That's the action. That's why we give it. But there are side effects to it. What are the side effects of the inhaler? Do what?
It increases the heart rate.
Yeah, it makes you tachycardic. It may make you anxious, give you the shakes a little bit. Because the way the medication works, it's a beta agonist, and it will dilate the bronchioles, but it increases the action of the heart. So that would be a side effect, a negative side effect. Okay, before you use the inhaler, remember the 5 rights. Make sure you go through those. Make sure that it hasn't expired. Make sure it's prescribed for that patient. And remember, before you can administer this or assist, you have to call med control to get permission to use it. So you want to shake it. It's not fluid in there. It's very fine powder that's ground up in there. And you shake it so that it it goes throughout the bottle and it's not just all down at the bottom. You shake it up, and then when you mist it, it's basically blown into the patient because it's under pressure. So it needs to be at room temperature. You don't want it cold or it's not going to work. So it needs to be at room temperature. Your patient has to be breathing spontaneously. They have to be alert. They have to be able to follow your instructions. So if you've got somebody in the midst of an asthma attack, when they're unconscious, laying out like this, they can't assist you with this. So it's not going to do you that much good. So they have to be alert enough to follow your instructions. Now, if it comes with a spacer, if the patient has a spacer, you want to use the spacer. As I said, when you shake it up and then you squirt it into the patient's mouth, it's coming out under pressure. It's being blown in there. And when you look at the shape of the mouth, if it's blown straight in here, it's not going straight into the lungs. Most of it hits the roof of the mouth. So the way we prevent it from just lodging, it's a powder, as I told you, to keep it from just lodging on the roof of the mouth, we use the spacer. So if the spacer's with it, it's very important that you use it. All right, this is a spacer called an aero chamber. But what it does is it delivers the medication into this chamber, and it kind of swirls around in there. And then when you breathe, you draw it, or the patient draws it into the lungs. It's different than if you just squirt it and it just goes into the mouth or the roof of the mouth. But if it's already mixed with air in this aero chamber, it's very easy for the patient to draw it into the lungs instead of into the mouth tissue. So what you want to do is have your patient exhale completely, like blow all of your air out. Then you're going to put their lips to it, and then have them ready to inhale. So as soon as they start inhaling, you squirt it, so they'll draw that in. And then once they draw it in, you want them to hold their breath, for 30 seconds or as long as they can, to help force that pressure in the lungs, will help force that into the alveoli. So then once they've done that, then they can exhale, and you want to put them back on your non-rebreather. Now, there's something called a nebulizer. It's a small volume nebulizer. In some services, EMTs can use it. EMTs don't use it in Alabama. But with the nebulizer, we actually put the albuterol into a little chamber, and we run oxygen through it with a little bit of water, and it aerosolizes it for you. It also delivers a lot more medication than the metered dose inhaler. So you just run oxygen through it. The medication goes down in here. It's got some fluid with it, and the medication and the force of the oxygen will put it into an aerosol so they can breathe it. But the patient has to be breathing spontaneously. They have to be able to follow instructions. I already told you that. And then we call this a breathing treatment, and it may take them 3 to 5 minutes to complete a breathing treatment. It's much more effective than the nebulizer. All right, review. Very slow and shallow respirations are often the end point of a serious condition that are a precursor to death. And I want to give you a name for that type of respiratory pattern. What is it? Yeah, downhill. These are agonal respirations. I remember it because it's like agony. This is somebody that's FTD. So when their respiratory rate slows down, we're talking about 4 or 5 per minute. It will become very irregular. It may be very shallow, or they may have a big gasp. We call that agonal respirations. I heard an old lady, an old LPN years ago, she called it the death rattles. Yeah, she got the death rattles. Yeah, that's the death rattles. Okay, you want to make sure you get a good history. By getting a history, you may be able to get a good differential diagnosis. Differential diagnosis is important when you're trying to decide what's wrong with your patient and how you're going to treat him. You've got to do a good OPQRST to try to determine what's wrong with your patient. Respiratory distress just looks like respiratory distress, but until you get a good history, you're not going to be able to tell what's the cause of that respiratory distress. Look at their work of breathing. If they're working hard to breathe, they're not going to last long. If they're bent over in a tripod position and they are working hard, they might be breathing fast, but soon they're going to be breathing slow, and then they're going to keel over, and then you're going to be bagging them. They may be on medications. What medication do we deliver to our respiratory distress patients? Oxygen? Yeah, albuterol through a metered dose inhaler in most cases. You're going to have to determine what, you have a question?
But we can give albuterol through the nebulizer.
It's not in the Alabama state protocols for EMTs at this point. But if you're working on a paramedic truck, you very easily do it. You know, it's not that big a deal. So you have to determine if the patient's breathing adequately, inadequately, or not at all. That's going to be at the beginning when you're assessing your patient. And then you're going to have to decide how you're going to provide oxygen to them. Don't forget that cutoff at 95 and below, you're going to give them oxygen. It may be through a non-rebreather. It may be through a bag valve mask. If it's above that, if they're 97, 98, it's going to be dependent on how bad they are and what's wrong with them. You know, if it's they've got respiratory distress, they're getting oxygen. So that's one time you always will, and then just depending on how bad they are. Okay, don't forget to ask them if they have an inhaler. You forget. We all forget. The patient forgets. They're so stressed about not being able to breathe, they forget they have an inhaler, so they don't use it. If it's appropriate, call med control. Ask permission to assist them with that. Make sure the patient fits the parameters. You know, if they've got chest pain, they don't need an inhaler, okay? If they've got chest pain, what do we give them? Oxygen, aspirin, nitro, yeah. Patient assisted for cardiac chest pain. What would you expect a patient's respiratory rate to do when the patient gets hypoxic? It's going to increase. If they're hypoxic for a long time, what's going to happen? It's going to decrease and then, yeah. What would you expect a patient's pulse to do when they're hypoxic? That's right. Okay, you got a 72-year-old female complaining of severe shortness of breath. Her husband notes that she is confused. You know the respiratory rate is 8 breaths a minute, and she's got cyanosis. Patient has a history of COPD and CHF. What's CHF? Congestive heart failure. Discuss the treatment steps to assist this patient. Number one, what are you doing? We're bagging them because
they're not breathing active.
yeah, number one, 8 times a minute. Number two, she's confused, which is because she is what? Hypoxic. This tells you also that she is hypoxic. Yeah, absolutely. Number one, we're bagging this patient. Ta-da! Okay?